Hey everyone, and welcome to The Explainer. Today we are putting on our nursing hats and diving deep into prenatal care. We're going to focus on two skills that are absolutely crucial. First, how to navigate all those key tests that monitor a pregnancy, and second, how to spot the red flags when things start to go wrong. This is all about helping you move from that feeling of uncertainty to taking confident, life-saving action.
So, here's our game plan. We'll kick things off with the nurse's unique role in all this. Then, we'll clear up the confusion between screening and diagnostic tests. From there, we'll get into the serious stuff, early pregnancy alarms, then late pregnancy emergencies. And we'll wrap it all up with a practical, clinical toolkit packed with key labs and meds you need to know.
Before we jump into the hardcore clinical details, let's just ground ourselves in what our role really is. You know, as nurses, we're so much more than just people who report numbers or help with a procedure. We are right there in the middle of it all, handling patient education, giving that vital emotional support, and really guiding families through some of the toughest decisions they'll ever have to make.
This quote just nails it, doesn't it? We are that bridge. Think about it. We're the translators who turn complicated medical jargon into something a scared parent can actually understand. We're the advocate, the steady hand. You're going to see this theme pop up again and again today.
Okay, let's get into part one, decoding the signals. We have to start with the big one, the difference between screening and diagnostic tests. Honestly, this is a huge point of confusion for pretty much everyone, patients and new nursing students alike. Getting this right is absolutely key.
So first up, we've got screening tests. The best way to think about these is like casting a really wide net. They're all about estimating risk. They might use blood work or an ultrasound to see if there's an increased likelihood of something going on. They basically raise a flag and say, hey, we should maybe look closer here. But, and this is the important part, they do not and cannot give you a definitive yes or no.
So where do you get that yes or no answer? Well, that's where diagnostic tests come in. These are the follow-up. The next step after a screening test comes back with a red flag. We're talking about procedures like an amniocentesis or chorionic villus sampling, which you'll hear called CVS. These tests actually get a sample of fetal cells so they can confirm or completely rule out a condition with incredible accuracy. And if you ever need to explain this to a patient, this analogy right here is golden. Just tell them a screening test is like a mammogram. It's great at finding a suspicious spot that needs a closer look. But the diagnostic test, that's the biopsy. It's the thing that tells you exactly what you're dealing with. It just clicks for people.
But here's the catch. Getting that definitive answer isn't without risk. These diagnostic tests are invasive. For example, a CVS procedure carries about a 1% risk of pregnancy loss. And this is exactly where your nursing skills become so critical. Our job is to sit down with that patient, provide clear, unbiased counseling, and make sure they truly understand the risks so they can make a choice that feels right for them.
All right, let's switch gears. We're moving from routine monitoring to managing complications. And we're going to start with one of the most terrifying symptoms a person can experience in early pregnancy, bleeding. We need to know the 3 most common causes of hemorrhage before that 20-week mark. So here are the big 3 you need to have on your radar. A spontaneous abortion, which is a miscarriage, an ectopic pregnancy where the embryo implants somewhere it shouldn't, like the fallopian tube, and gestational trophoblastic disease, or GTD, which you might also know as a molar pregnancy. Recognizing the telltale signs of each one is a must-have skill.
This table is basically your clinical cheat sheet. You got to learn to see the patterns. For an ectopic pregnancy, you're looking for that one-sided pain, right? Especially if their HCG levels are weirdly low or just not rising like they should. For GTD, that molar pregnancy, the classic signs are that dark brown, prune juice bleeding, crazy high HCG levels, and a uterus that feels way bigger than it should for the dates. Miscarriage can look like a lot of things, but you'll often see cramping with it. Your assessment skills are what will lead you to the right answer.
So, when a patient presents with these symptoms, what do? You fall back on your training. You use the nursing process. It always starts with a solid assessment. Vitals, check the bleeding, assess the pain. Then you plan. Get this patient stable, get ready for whatever might come next. Your interventions are where you shine. Get an IV going for fluids. Give RhoGAM if mom is Rh negative, and please never forget the emotional support. Then you evaluate and you teach. This is what it looks like in the real world.
Okay, let's fast forward to late pregnancy, where things get even more intense. Bleeding in the 2nd or 3rd trimester, this isn't just a concern, it's a full-blown, life-threatening emergency for both mom and baby. We're going to zero in on the 2 big ones, placenta previa and placental abruption.
All right, let's do a quick clinical scenario. Your patient comes in, she's in her 3rd trimester, and she's bleeding. She tells you the blood is bright red, and when you ask about pain, she says, nope, doesn't hurt at all. What is the #1 thing that should be screaming in your head right now?
If you thought placenta previa, you are absolutely correct. This distinction right here, you have to burn this into your brain. Placenta previa is painless, bright red bleeding, and the uterus feels soft. Placental abruption is painful with dark red blood, and the uterus is firm, rigid, and tender. Painless previa, painful abruption. It's one of the most important differentiations you'll ever learn in OB.
And listen up, because this is a safety alert you can never, ever forget. If you have any reason to suspect placenta previa, you do not perform a vaginal exam, ever. The placenta is literally covering the exit. A vaginal exam could tear right through it and cause a catastrophic hemorrhage. It is an absolute, non-negotiable contraindication.
All right, we're in the home stretch. For our last section, let's put together your clinical toolkit. We've talked about the conditions, so now let's talk about the specific labs and medications you'll use to manage them. This is the practical stuff you'll need on the floor. This slide really connects all the dots for you. See how an abnormally high HGC points you toward GTD, while a low or plateauing level screams ectopic pregnancy, which you might treat with methotrexate. A dropping hemoglobin tells you there's a bleed somewhere. And of course, knowing the patient's RH factor tells you if you need to give Rogam. I'd go ahead and take a screenshot of this one. It's the perfect quick reference for your clinicals.
So I'll end on this thought. You're the one at the bedside. You spend more time with the patient than anyone else on the healthcare team. You are the first line of defense. And your sharp assessment skills, your knowledge of these red flags, and your courage to speak up can literally save a life. So the question isn't just what you know, but when that patient's story or their vital signs just feel a little off, what's that subtle sign that you're going to be the one to catch? That right there is the power of a great nurse.